Hi, everybody. Dr. Daniel, and today I'm talking about footballers' migraine. Well, what has come to be called footballers' migraine is really a syndrome of symptoms of fortification visual images, numbness, and paresthesia, usually occurring on one side of the body, in the arm and face, and rare hemiparesis, followed by throbbing headache, much like that of an attack of migraine with aura. These events occur minutes after mild, usually non-concussive head trauma, such as may be sustained in soccer, boxing, or mild accidental head trauma. Many of the patients may have spontaneous typical migraine before or after the traumatic event, and most of them have a history of migraine in their family. Footballer, in this sense, refers to a soccer player, not an American-type football player. Footballer's migraine is not mentioned in ICD-3, the International Classification of Headache Disorder. Most cases concern patients with migraine who develop symptoms of migraine with aura, which are visual, numbness, language trouble after mild concussive head injury. However, Whitty's case in 1967 had no headache. In Matthews' 1972 article, all his patients had visual symptoms and membranous paresthesia followed by headache, but his case 3 also had difficulty with speech. Haas, H-A-A-S, and Sumner in 1969, writing about migraine attacks triggered by mild head trauma and the relation to certain post-traumatic disorders of childhood, reported in children leg weakness or hemiparesis, slurred or garbled speech, membranous paresthesia, lethargy or sleepiness, and vomiting. Morris, in a letter to the British Medical Journal in 1972 regarding his own experiences following blows to the face after tackles playing rugby, described lightheadedness followed by 15 minutes by anonymous hemanopsia with fortification spectrum and tingling of the hand, side of the face, and tongue. Tiredness and nausea followed about 2 hours later, lasting several hours. Morris did not describe headache. Haas et al. In 1975, writing in Archives of Neurology about juvenile head trauma syndromes and their relationship to migraine, described 4 clinical types: hemiparesis, somnolence, irritability and vomiting, blindness, and brainstem signs. Literature review. There are few references in the early neurologic literature. Graham, writing in 1966 in the Handbook of Clinical Neurology, referred to youngsters with classical migraine who develop a characteristic attack when hit on the head in a football match. Whitty, writing in 1967 in Lancet on migraine without headache, mentioned a patient who had migraine which had been induced by boxing in his youth. Whitty's case 6 followed. A man aged 55 for 12 months had had attacks of fortification spectra, followed by numbness and paresthesia in the hand, arm, and face. Symptoms were on both right and left sides and lasted 1/2 to 1 hour. Speech was not affected, but he could not write properly when the right hand was involved. No headaches, nausea, or vomiting. Apart from chronic bronchitis with productive winter cough, he was otherwise well. Skull x-rays and an EEG were normal. Family history of typical migraine with a visual aura in a first cousin and in a maternal aunt. 30 years previously, when an amateur boxer, he had had attacks of numbness and weakness of the left side, lasting 1/2 to 1 hour, and associated with throbbing headaches after fights in which he received punishment to the head. They ceased when he gave up boxing. Matthews, writing on the subject footballer's migraine in the British Medical Journal in 1972, stated that migraine may be a formidable obstacle to the enjoyment of life, but is less well known as an occupational hazard and a threat to professional advancement. I've encountered a classical migraine, including incapacitating visual field defects occurring only when playing football and precipitated by head trauma in 5 young men, 2 whole-time professionals, 1 a part-time professional, and 2 amateurs. 2, including the part-time professionals, had given up the game on this account. Case 3 from Matthew's article follows. A boy of 12 was playing somewhat inexpertly in goal when he was struck on the side of the head by the ball. Within a few minutes, he complained of blurred vision and a little later developed numbness to the right hand and difficulty with speech. As this improved, it was followed by a severe headache, and he was taken to a hospital casualty department by an alarmed games master. The almost equal alarm aroused in the casualty officer was allayed by the boy's rapid recovery, and when I saw him a few days later, he was almost quite well. He had no previous history of migraine, and his subsequent prognosis is unknown. Matthews pointed out that a diagnosis of migraine was certain in his patients, and that the circumstance of focal and concerning neurologic symptoms of visual change and paresthesia, along with severe headache occurring after a blow to the head, caused great concern in the mind of attendant officials and medical personnel who naturally feared some much worse neurologic conditions such as an aneurysmal rupture or subdural hematoma had occurred. Matthew continued in his report, migraine induced in this way is not common among footballers and is not mentioned in the standard text on sporting injuries. The ball weighs from 14 to 16 ounces, that's 400 to 450 grams, at the beginning of the game, and although the modern waterproof ball does not increase weight by the 20% common with the leather ball on a wet pitch, the impact, even when traveling at the quite ordinary speed of 30 miles per hour, is not inconsiderable. The footballer is trained to meet the ball from whatever direction it comes and whatever its intended destination in a restricted area in the midline in the frontal region. The neck muscles are contracted, and the force of the contact may be increased by a sharp movement of the head. Haas and Sovner pointed out that early reports about patients beginning their career in migraine after suffering head trauma do not include patients having individual migraine attacks minutes or hours after a blow to the head. They reported 5 cases of migraine attacks triggered by mild head trauma with a variety of neurological manifestations as part of the attacks. 3 of the cases occurred without headache. Case 4 from their paper follows. RG, a 19-year-old man, has had 4 migraine attacks. The first was at age 12. On Saturday afternoon, he had been briefly stunned by a blow to the head while playing football. On Sunday morning, he was awake with a mild headache. 1 hour later, he got paresthesia in his left hand, forearm, and arm. All symptoms faded shortly. The second attack was in June 1967 at age 17. He recalls being hit on the head and believes that the trauma was related to the attack, but the temporal relationship between the two had slipped his mind. The third attack was March 1968 at age 18. About 1:15 in the morning, he was hit forcefully on the lip in a fistfight and was momentarily stunned. At about 3 a.m., while sitting in a car, he noted numbness in the tips of left fingers. This sensation quickly ascended to involve the entire left upper limb and the left side of his lips, tongue, and nose. At the same time, he developed a severe right supraorbital headache with nausea. The numbness faded an hour, and he slept off the headache. The fourth attack was on 20th April 1969 at age 19. At 11 a.m., he carelessly struck his head against the arm of a couch and was momentarily stunned. At 12 noon, a right or supraorbital headache began and soon was severe. Later, nausea and vomiting occurred. At 1 p.m., numbness began in his left fingertips and soon spread to involve his entire left upper limb and the left side of his lips, tongue, and nose. His left hand became clumsy, and he had trouble in writing. He is left-handed. He lost left-sided vision. The numbness and hemanopia faded away in several hours, but the headache lasted some 12 hours. Neurological examination just after the end of the headache showed slight clumsiness of the fine movements of the left hand and slight rotary horizontal nystagmus on lateral gaze. The next day, the examination by one of us was normal. In 1975, Haas et al. Wrote on the juvenile head trauma syndromes in relationship to migraine in the Archives of Neurology. They reported 25 patients who had 50 attacks of, quote, temporary neurology phenomena triggered by head trauma, period, end quote. The age of their patients ranged from 2 to 38 years old. The head blows that started the attacks were strong enough to daze the patient momentarily. 2 blows produced brief loss of consciousness. In almost all attacks, a history of a latent period between the head trauma and the onset of neurologic symptoms occurred. One of Haas's et al. Cases with hemiparesis follows. One June 1st, 1972, a 14-year-old boy was struck forcefully on the right side of the head with a large rubber ball. Moments later, he noticed difficulty seeing in the right visual field. Severe left posterior cerebral headache began in 30 minutes. 1 hour later, he experienced fluctuating numbness in the right side of the face, arm, and leg, vomiting, and difficulty in speaking. Several hours after the trauma, examination in the hospital revealed mild dysphagia, right homonymous hemanopsia, and mild right hemiparesis. A few hours later, the visual field defect and the hemiparesis disappeared, and the next day, the dysphagia and headache faded away. 4 similar previous episodes had followed mild head trauma, the first at age 11. Ashworth, writing in 1985 in the Scottish Medical Journal on migraine, head trauma, and sport, describes 7 patients who developed an attack of migraine by hitting a football or a blow in the face in a rugby tackle. Ashworth stated, "The attack is sometimes alarming and clearly cannot be explained on the basis of trauma alone. Some people only have attacks in this particular circumstance, but the majority have spontaneous episodes at other times." That's like migraine. McCrory et al. Wrote on prevalence of headache in Australian footballers in 2004 in the British Journal of Sports Medicine, in which they surveyed the prevalence and risk factors for headache in a population of elite professional Australian footballers. A total of 160 headache questionnaires utilizing ICD-2 criteria were studied, and headaches were found in 80% of players, with 45% reporting headaches during match play and 60% during training. In the footballers, 22% of headaches conformed to ICD-2 definition of migraine, but when the less strict definition of footballer's migraine was used, 34% of headaches met these criteria. The authors concluded that headaches are common in Australian footballers, and the syndrome may not be properly identified using only a strict ICD-2 definition of migraine. Pathophysiology. Most of the articles on this subject date about 30 years ago, when the prominent and sole cause of migrainous neuralgic events were thought to relate to arterial spasm, which was the ARA, and arterial vasodilatation of the headache. But that's kind of outdated, old theory and not currently intact. Currently, cortical spreading depression. The current view of the pathologic changes in these patients with footballers' migraine is that trauma induces Liao's cortical spreading depression, a reaction of neuronal and glial depolarization which passes like a wave over the cerebral cortex and then resets. Retreatment for this. You advise the patient and their family to not do football or to do active contact sports. And also you can treat them with any kind of just regular migraine treatments such as sumatriptan. There's really not much articles written about that. So if you would follow me on my webpage, drmigraine.com, I've got pictures and I have a bibliography listed there. So thank you very much for listening to this talk, and please subscribe down there, and I'll see you again on the next talk.